Welcome to Medical Logistics 101 Chest Pain Overview. This video is for educational purposes only. It is not medical advice, does not replace a medical evaluation, and may not apply to your situation. If you have symptoms or concerns, please speak with a licensed healthcare professional. My goal is to help patients enter healthcare with a map instead of a blindfold, and to explain how clinicians think through these problems in resource-limited settings. Chest pain categories, I like to think of these as broadly several categories. Cardiac causes include ST elevation MI or STEMI, non-ST elevation MI, stable and unstable angina, and arrhythmias. Lung causes, pulmonary embolism, pneumothorax, infections. Other causes, aortic dissection, musculoskeletal causes, pleurisy, anxiety, shingles. Red flags, atypical symptoms that you have to be on watch for. Chest pressure, pain radiating to the jaw, the arm, or the back. Sweating, nausea, feeling faint, syncope, sudden sharp pain with shortness of breath. History of heart disease or risk factors. Recent history of long travel or immobility. Heart-related causes, heart attack, aka STEMI. This is a specific EKG finding, and as I said, non-STEMI, which is a specific finding, but it's not of the same urgency, I would say, as someone having an ST elevation MI. Chest pressure, heaviness, squeezing sensation. Patient may describe a weight on their chest. Pain may radiate to the neck, the back, the shoulder, or left arm. Heart-related causes, angina, pain with exertion, often improves with rest. Pericarditis, sharp chest pain, worse when lying flat, often improved by leaning forward. Aortic dissection, uncommon but very deadly. Patients may describe it as a sudden severe chest pain with a tearing sensation, often radiates to the upper back, may have a history of syncopal episode. Lung-related causes, pulmonary embolism, sudden shortness of breath, sharp pain, elevated heart rate, history of recent travel, recent surgery or mobility, history of cancer, all these raising your risk for thromboembolism. Pneumonia, classic symptoms you would expect, fever, cough, pain with breathing. Chest x-ray is obviously going to be very helpful diagnosing that. Lung-related causes, pneumothorax or collapsed lung, can be spontaneous or trauma-related. Usually described as sudden, sharp pain. Oftentimes, for the people that have them spontaneously, they'll oftentimes be tall, thin, young men. I have seen patients who had a history of lung emphysema or lung blebs that suddenly ruptured and produced a spontaneous pneumothorax. They can be, they can be large or small, much like pulmonary emboli, and the amount of lung involved can be large or small. If it's a small pneumothorax, you can have what's called an apical pneumothorax up near the top of the lung, near the clavicle. These are a little harder to see, but generally speaking, chest x-ray is going to be very helpful in diagnosing a pneumothorax. Other causes, gastroesophageal reflux disease or GERD, aka heartburn. Burning sensation, worse with meals, often improves with antacids. Usually upper abdominal pain, what we call epigastric pain. It's a diagnosis of exclusion for me. I want to rule out other serious causes before saying that someone's chest pain is due to GERD. Musculoskeletal causes, again, you're going to expect chest wall tenderness, point tenderness on exam, maybe tender where their ribs meet their sternum, costochondritis as it's called. More of a diagnosis of exclusion for me after I've ruled out other more serious causes. Shingles, interesting. Shingles can develop before the rash develops. You may have pain in that dermatome, and at the time you see them, they may not have the rash yet. But it's going to be on one side, and it's going to be in one area, one specific area of that sensory dermatome. Silent groups, atypical symptoms. Certainly, women are known for having atypical symptoms with regard to heart attacks. Diabetics, older adults, neck or jaw pain, shoulder, upper back pain, people with epigastric pain, upper abdomen. I always get an EKG on these people. I don't care how many times they tell me it's just my reflux, it's just my GERD. I'm going to get an EKG on those patients. Early EKG, the EKG catches the ST elevation MI immediately and directs care. Other causes of chest pain, we're also going to take it very seriously and you're going to work it up. But if you have someone having a STEMI, a lot of things happen very quickly, whether you're in the rural setting or certainly even in the urban setting. Every minute delay equals more heart muscle lost. Going to the ER by POV equals delayed recognition and delay in getting that initial EKG, which is so important. EMS can activate resources before arrival and stabilize the patient. The first thing that EMS is going to do when they arrive to a scene, someone's complaining of chest pain, they're going to get an EKG after stabilizing the patient. And they, if they see that someone is having an ST elevation MI, they're going to call ahead and activate that system, which may include a cath lab, or if you're in the rural setting, they may be potentially thrombolytic medications. But again, that early recognition starts the treatment protocol immediately. As you can imagine, the problem is a busy ER waiting room. Add to that maybe someone having atypical symptoms like the neck or jaw pain. This could mean a delay in recognition and a delay in getting that EKG. And a 30-minute delay of someone having an ST elevation MI is devastating. Rural hospital setting, they can certainly diagnose a STEMI and other EKG abnormalities. They can stabilize the patient. They can give thrombolytic medications to reestablish that blood flow when it's appropriate for the patient, appropriate for them based on their potential criteria that might exclude them from getting the medication. But it can be absolutely a life-saving medication, and I've given it before. They start transfer immediately, and transfer time is baked in. That's the problem. They realize that, well, that some patients might ask, why don't they just simply send me to somewhere that has a cath lab? Because the amount of time involved would take too long, and you would lose too much heart muscle in the meantime. The rural settings are not going to have a cath lab. They're not going to have a cardiologist. They won't have surgical backup likely. Our goals for that most serious EKG finding, the ST elevation MI or STEMI, cath lab goal is 90 minutes from the time of arrival. In other words, from the time you arrived and you got the EKG that showed you had a STEMI, ideally you should be having that vessel opened up again in the cath lab. In the rural setting, which you're going to be giving a medication through an IV, the thrombolytic, if you meet criteria and don't have anything to exclude you from getting that, that would be ideally 30 minutes from the time of arrival when you get, again, the EKG on arrival. Delays in getting that initial EKG equals delays in activation and treatment. What to expect in the ER? When you first arrive, they're going to get an EKG as well as doing a physical exam and vitals. Blood test, complete blood count, complete metabolic panel, serial troponins, possibly a D-dimer. I'll say this, the troponins, this is going to be done as someone that is stable, they're not having a STEMI. I'm not basing the diagnosis of a STEMI on your troponins. That's based on your EKG and what I see when you first arrived. The serial troponins, if I was having a heart attack at this instant and you drew blood work and you checked your troponin, it may appear normal. It won't stay normal, obviously. So that's why we get serial troponins and look for a change in those. But the diagnosis of a STEMI is based on that EKG, not lab work. The D-dimer, again, that's going to be someone if you're looking for other causes, like a pulmonary embolus. Chest x-ray. Now, the chest x-ray that you're going to get with this chest pain patient is usually going to be a portable chest x-ray in the exam room, not a chest x-ray down the hallway. Because ideally someone is having chest pain, they need to be where they can be stabilized in the ER, not in radiology. Other things, you may have a possible bedside ultrasound to look for potential, for example, an aneurysm or it's a dissecting aneurysm. Cardiac monitor, always just standard of care. We want you on continuous cardiac monitor to see what your rhythm is and look for changes on your EKG. As well as a CT scan. That may be done if someone's initially found to be stable, they're not having an ST elevation MI, and I want to look for a pulmonary embolus. Possible admission or discharge or close follow-up. If you completed the workup and you are felt to be stable and you're not having an emergent situation, then you may be discharged, but it doesn't mean everything's okay. It means you need to have close follow-up, usually with a cardiologist. Closing, if you find this kind of content helpful, please like and subscribe. If there are topics you would like to see covered, you can certainly email me at medicallogistics101@gmail.com. Remember, the danger isn't always what you know, but rather what you can't afford to miss. Thank you.